And now this is my pleasure to introduce Dr. Pasquale Nardelli, which comes from San Raffaele Hospital in Milan, Italy. He will talk about improving oxygenation and hemodynamics. Please, Pasquale, the floor is yours.
Thank you, Dr. Gaudrad, for your introduction, and thanks to Professor Landoni and Professor El-Tahan for inviting me to the webinar. So, first things first, to talk about improving oxygenation requires a definition for optimal oxygenation targets. Current ARDS and ECMO guidelines fail to identify these thresholds, so the debate, in my opinion, is still open. To understand how low can we go, we should look at those who went high. The New England Journal of Medicine published in 2009 a landmark study in which arterial blood samples were obtained from climbers at the summit of Mount Everest, over 8,000 meters high, showing remarkably low levels of arterial oxygen pressure, around 20 millimeters of mercury, in healthy asymptomatic subjects. While all subjects made it to the base camp, denoting they were fine at the time of sampling, their brain probably wasn't. Almost all climbers returning from the summit of Mount Everest show silent hypoxic cerebral lesions at MRI scans. So oxygen conformance is the technical term to explain how human body adapts to hypoxia. It is usually reversible and not associated to long-term effects. However, critically ill patients may lack such an ability. So I think that to get deeper into the discussion about the oxygenation threshold, we should also take into account the following factors. The fact that the ratio P over F upon admission does not predict outcomes reliably in ARDS, the fact that blood hypoxemia does not always relate to tissue hypoxemia, and the latter is the one that matters, and the fact that ARDS survivors have a high prevalence of cognitive impairment upon discharge. So while as I was saying before, guidelines in this area are vague, and also recommends to keep saturation above 80% while focusing on rest ventilator setting, nothing else. So the matter is still open. I think that a modern approach to the matter should not rely solely on a crude number, but rather aim at an oxygenation level allowing the patient to breathe spontaneously without distress and actively taking part to the healing process. So let's try tackling the issue from the beginning, and let me talk briefly about mathematics. The delivery and the uptake of oxygen in the human body are regulated by equations, which represent the cornerstone to understand the physiology of ECLS. Critically ill patients require between 200 and 500 milliliters of oxygen per minute, and extraction is around 30% of circulating oxygen. Therefore, target oxygen delivery should be about around 3 times oxygen consumption. DO2 over VO2 ratio, optimal DO2 over VO2 ratio should be around 3. Everything we're going to see in the next few minutes will aim at optimizing the ratio between oxygen delivery and oxygen consumption. Let's have a look at ECMO. So what happens in a fully dependent ECMO physiology with lung function approaching 0 and without significant recirculation? Oxygen delivery will result from the mix of the blood flowing through the oxygenator, which will come out at with an arterial pressure of oxygen around 450 millimeters of mercury, with the amount of cardiac output exceeding the ECMO flow that will have the same concentration of venous blood. So we know that in general, initiation of venous ECMO will improve systemic oxygenation. Matter of fact, there are a few factors that within a few minutes of ECMO initiation will bring systemic oxygenation down. And I think these factors must be taken into account when addressing the strategy of venous support. So first, the reduction of pulmonary vascular resistances will increase right ventricular contractility and cardiac output, therefore decreasing the ratio between ECMO blood flow and cardiac output. Also, the presence of blood with high oxygen concentration in the pulmonary artery impairs hypoxic pulmonary vasoconstriction, increasing perfusion of previously shunted lung portions, which do not contribute to oxygenation. And finally, the adoption of a lung rest strategy will cause the recruitment of the lung and therefore hypoventilation. With this clear depiction of our enemy, hypoxia, let's have a look now to the weapons that we could use to start a fight. So, improving oxygenation in veno-venous ECMO can be done by acting on several different areas. We can work on increasing oxygen content in the blood, minimize recirculation, reduce oxygen consumption and manipulate cardiac output, reduce the shunt fraction both in the circuit and in the patient in his lungs, and to support right ventricular function. However, I think it's not about the single factor, but it's going to be a close interplay between all these elements that will factor into determining systemic oxygenation.